Hey, everybody. Welcome back to the National Council on Severe Autism webinar series. I'm Jill Escher. I'm the president of NCSA, and I will be your host tonight. This is number 4 in our 2024 webinar series, and we return this evening to the topic, to a medical topic that is of enormous relevance and importance to our severe autism and IDD community, and that is seizures and epilepsy and the treatment thereof. We have a very, very, very special guest with us, and that is Dr. Stephanie Morris, our presenter. Dr. Morris is medical director of the Center for Autism Services, Science, and Innovation, otherwise known as CASSI, at the Kennedy Krieger Institute in Baltimore, Maryland. She's a neurologist with special qualifications in child neurology and is also an assistant professor in the Department of Neurology at the Johns Hopkins University School of Medicine. She works with kids with autism and IDD, and especially with genetic conditions just such as Fragile X and Neurofibromatosis Type 1. She was previously on the faculty of Washington University. Dr. Morris is not only a clinician, but she is also a researcher, and she has grants and funding through the National Institutes of Health, looking at things like genotype, phenotype correlations, meaning like if you have a certain genetic condition, what might the clinical outcome be? And she's worked on many other projects as well, and you will learn much more about her. My only other preliminary bits for context here are you definitely can use the chat, but if you have questions for Dr. Morris, I prefer the Q&A because I often like get lost kind of toggling between everything. So Q&A is preferred. You can use the chat too if you want to just chat with everyone, make a comment. And I am recording this, and it will be posted hopefully this evening to our website. So if you have to step out, don't worry. With that, I turn it over to Dr. Stephanie Morris, and you can share your screen.
Great. Thank you so much, Jill, for that lovely introduction. Let me get my slides pulled up here. Okay, can you see that okay?
That looks great.
Perfect. Well, thank you everybody for joining this evening, and like Jill said, for taking the time out of your Wednesday evening to be here today. I'm Stephanie Morris. I'm a pediatric neurologist and an autism doctor. I'm in Baltimore, Maryland at the Kennedy Krieger Institute. And I'm just really, really grateful to be here with everybody tonight. Tonight, our topic of conversation is seizures and epilepsy in severe autism. Oh, let's see if I can advance. There we go. I don't have any disclosures. I don't have any financial or non-financial conflicts of interest that are related to this presentation that I need to let anybody know about. And I have a lot of objectives today. This is going to be a really high-level overview of a lot of different pieces related to seizures and epilepsy. We'll go over the objectives here real quickly. So we're going to review the prevalence of seizures and epilepsy and autism, identify risk factors for the development of epilepsy in autistic individuals, review what a seizure is and the various seizure types. We'll review how a diagnosis of epilepsy is made. We'll outline what to do when or if a seizure occurs, and we call this seizure first aid. We'll review the medical evaluation of seizures, primarily related to the use of EEG and MRI. We'll discuss EEG abnormalities in autism, including a brief conversation about ESES and the association with regression syndromes. We'll review a little bit about the treatment of epilepsy. We'll discuss SUDEP, which is the sudden unexplained death in epilepsy, very briefly. And then I'll finish off with some helpful tips. All right, so why should we care about seizures in our severe autism population? Well, the rate of epilepsy in all autistic individuals is variable depending on what paper you read, but is generally quoted to be around 20%, although generally ranges anywhere from 10 to upwards of 80%, depending on what paper you're reading. This is significantly higher than the general population, where the rate of epilepsy is quoted to be around 1%. We know that the rate of epilepsy is significantly higher in autistic individuals who have co-occurring intellectual disability, with the highest rate of epilepsy in autistic individuals who have an IQ of less than 40, and that's quoted to be around 46% and has been pretty stable around that number. There was a really great study that was published in 2013 that looked at a sample of over 5,000 autistic children over the age of 10 that demonstrated that for every 10-point increase in IQ, the odds of having epilepsy decreased by about 47%. So, what that means is that individuals with profound autism are at the highest risk within the autistic community for developing seizures. In recent years, owing primarily to the rapid progress of genomic technologies that have become available to us, many genetic variants have been identified that confer increased risk for autism, intellectual disability, and epilepsy. Although the mechanisms right now are not completely understood, there have been some proposed biological mechanisms that provide possible explanations for this association. The leading theory is that neurodevelopmental and epileptic phenotypes arise from the same genetic risk and biological pathways. Another possible explanation is that neurodevelopmental-like symptoms arise secondary to epileptic seizures and epileptiform abnormalities that occur in this population. And probably the least likely explanation that has been proposed is that neurodevelopmental and epileptic phenotypes develop independently by chance without any real causal relationship. Beyond intellectual disability and IQ being a risk factor for developing epilepsy and autism, we know that there are other potential risk factors that have been identified. Children who develop isolated regression, which is this loss of developmental skill primarily in the language domain, have been demonstrated to have increased risk for epilepsy. Children who have late onset regression in language, social, and cognitive skills, so late regression occurring later than 3 years of age, have been shown to be at increased risk. We know that age is a major risk factor. There are generally two peaks in which epilepsy occurs in autistic individuals, one in infancy and the other in adolescence. In those who get through infancy without developing epilepsy, that risk for epilepsy increases over time with the peak in adolescence, but continuing to increase until the third decade of life. And then there's also this possible female sex risk factor. In studies that have looked at the rates of autism in those with epilepsy, we found an attenuated male to female ratio of autism in those with epilepsy of 2 to 1 compared to 3.5 to 1 in those without epilepsy, which is saying that girls who have epilepsy are much more likely to have autism than boys. Epilepsy is generally an unpredictable condition. Despite these identifiable risk factors, the development of epilepsy in any one individual is generally unpredictable to the clinician. We don't yet have any reliable predictive markers to help determine who will develop epilepsy, and so we rely on clinical clues to help identify seizures. There are many genetic conditions out there that are highly associated with both epilepsy and autism. However, even within these conditions, the development of epilepsy or autism is not guaranteed. So, what is a seizure? A seizure is a sudden, uncontrolled electrical disturbance in the brain that can cause changes in things like behavior, movements, feelings, and consciousness. They can last for seconds, minutes, rarely hours. They can occur at any time of the day or night. And an individual can also have multiple different seizure types, but each distinct seizure type typically looks the same in that individual every time that it occurs. We refer to this as being stereotyped. Seizures can be classified into two distinct categories, generalized and focal, sometimes called partial. Focal seizures generally occur from abnormal electrical activity that's being generated in one area of the brain, as you can see here in this second schematic. And generalized seizures generally occur from abnormal electrical activity that involves the entire brain all at once. Focal seizures are further classified into two categories: focal seizures with impaired awareness and focal seizures without impaired awareness. Focal seizures with impaired awareness generally involve a change or loss of consciousness, and focal seizures without impaired awareness have preserved consciousness and awareness of the seizure. Focal seizures can look a lot of different ways and can sometimes be really challenging to spot. Focal seizures with impaired awareness can be manifested as somebody who looks like they're awake with their eyes open, but staring off and not responding to their environment. They can appear awake, but confused, maybe repeating certain words, walking in circles, rubbing clothing, engaging in unusual behavior. Their eyes may be deviated to one side or the other, or perhaps rolled upwards. They may have repetitive jerking movements of the face or the limbs on one side of their body. They might develop stiffness involving the face or the limbs on one side of their body. And there's usually no memory of the seizure or awareness that it's occurred. Focal seizures without impaired awareness can also be quite variable in the way that they manifest. Sometimes they can present with a sudden change in emotion, so feeling sad or angry or joyful without there being any clear emotion-inducing stimulus prompting it. It might just be a simple tingling or discomfort in the face or the limbs on one side of the body. Sometimes it can be repetitive jerking movements of the face or one or both of the limbs on one side of the body. Sometimes the individual might experience flashing lights or colors in their vision. Or maybe it's just a sense of nausea or a stomach upset that's unexplained. The individual is generally aware during the seizure and has memory of the event. And sometimes when it's just a sensory symptom like tingling or flashing lights, we have to rely on the reporting of the symptoms by the individual because it's not otherwise clinically apparent to us. Focal seizures, as you can imagine, reading these descriptions can be incredibly challenging to identify clinically, especially within the autism community. The symptoms might be obscure, they might not be clinically visible, they may not be able to be relayed by an individual, and they oftentimes will mimic behaviors that we're seeing already in the context of autism alone. Generalized seizures can be classified into multiple different subtypes. There's absence seizures, atonic seizures, myoclonic seizures, tonic seizures, clonic seizures, and tonic-clonic seizures. Focal seizures, like we just talked about, that start in one area of the brain, can also spread to involve the entire brain and result in what's called a secondarily generalized seizure. Generalized seizures look very different from one another depending on what the subtype is. Absence seizures, also known as petit mal seizures, generally present with eyes open and staring off, sometimes with a little bit of lip smacking or perhaps a little eyelid fluttering. They're usually brief, lasting only 5 to 10 seconds or so, with a rapid return to the baseline. They can occur up to hundreds of times a day and can often occur in clusters, occurring one after another. They can be incredibly challenging to spot unless you're watching the individual very closely. Atonic seizures are also known as drop seizures. They're sudden, brief loss of muscle control that results in a rapid fall to the ground or a simple drop of the head. Myoclonic seizures are sudden, brief jerks or twitches involving the arms or legs, usually without an associated loss of consciousness, and these can be very brief, less than 1 second. Tonic seizures are stiffening of the entire body, typically involving the jaw, torso, hands, arms, legs, and feet, usually associated with a loss of consciousness, and if the person is standing, often results in a fall to the ground. Clonic seizures are repetitive jerking involving the neck, face, and arms, usually on both sides of the body. And tonic-clonic seizures, also known as grand mal seizures, which are generally considered to be the most severe type of seizure, is a sudden loss of consciousness with whole body stiffening, often resulting in a fall to the ground, followed by repetitive jerking of the face, neck, arms, and legs. Generalized tonic-clonic seizures are often associated with loss of bladder or bowel control, and oftentimes there's biting of the tongue due to jaw clenching. So what causes seizures? Seizures can be caused or triggered by many, many different things, including brain injury, alcohol or drug use or withdrawal, metabolic disturbances like having a blood sugar that's too high or too low, electrolyte imbalances like having a low sodium, kidney or liver dysfunction. High fevers can sometimes cause seizures, infection like meningitis or encephalitis, stroke, brain tumors, and some medications can cause seizures as well. However, the most common cause of recurrent seizures is epilepsy. Epilepsy is defined as a chronic neurological disorder that's characterized by recurrent seizures. A diagnosis of epilepsy is actually pretty straightforward. We can make a diagnosis of epilepsy when an individual has 2 or more seizures occurring more than 24 hours apart without any clear provoking or triggering factor. Or we can make a diagnosis if an individual has had 1 unprovoked seizure and is determined to have at least 60% probability of having another one within the next 10 years. Most seizures are self-limited, and basic first aid is all that's required. When helping somebody who's having a seizure, you can remember 3 words: stay safe inside. This is a schematic here from the Epilepsy Foundation that I think is a really nice representation of what you guys should be doing if you encounter somebody who has a seizure. It's available on their website in many different languages. It can be printed out as a poster to have with you or to give to caregivers. The first thing to do is stay with the person until they're awake and alert after the seizure. We always advise people to time the seizure so that you know when it's time to call 911. It's important to remain calm, and it's also important to check to see if the person has a medical ID bracelet that might identify an underlying medical reason for why they're having a seizure, like known epilepsy or perhaps diabetes and their blood sugar is low. The second thing to do is to keep the person safe. If they're confused and walking about, make sure they're not walking into dangerous situations. If they're unconscious and on the ground, move things away from them so that they're not hitting themselves on any objects that might be nearby. Turn the person onto their side if they're not awake or aware. This will help clear their airway. And in the circumstance where they might vomit, it'll allow for the vomitus to come out of their mouth. You can loosen any tight clothing around their neck, and you can always put something small or soft under their head to soften it. Call 911 if the seizure is lasting longer than 5 minutes. I would also recommend calling 911 if the person doesn't return to their usual baseline after the seizure has ended. If the person has incurred any injuries, is otherwise medically ill or pregnant, you should notify first responders. If the person is having repeated seizures without return to baseline, go ahead and call 911. If it's their first time seizure, 911 should be called. If there's difficulty breathing or if a person turns blue around their lips, you can go ahead and call the first responder. And any seizure that occurs in water would require a response by a first responder. It's really important not to restrain somebody who's having a seizure, and it's really unnecessary to put anything into a person's mouth who's having a seizure. They might clench their jaw and bite their tongue, but they won't swallow or otherwise obstruct their airway with their tongue. Sometimes people are prescribed rescue medications, which we'll talk about a little bit later. If they have something like that, you can use it as prescribed. So how long is too long? Most seizures last less than 5 minutes and they stop on their own. A seizure that lasts for longer than 5 minutes, though, is considered a prolonged seizure and is referred to status epilepticus. Brief seizures that occur back to back without return to baseline, lasting for more than 5 minutes, which would be prolonged seizure clustering, is also considered status epilepticus. And status epilepticus is considered a medical emergency. And so that's when you call 911. Our medical evaluation for suspected seizures is fairly straightforward. The very first thing that we think about is something called an electroencephalography, or EEG. An EEG involves the placement of electrodes on the scalp to record the electrical activity generated by neurons in the brain. There are a lot of different types of abnormal EEG signals that we can see on an EEG, but the ones that we're most concerned about when it's related to seizures are electrical discharges that are not typically seen when neurons are communicating properly with one another. Abnormal EEG discharges are called epileptiform activity and can indicate an underlying predisposition for seizures. Although prevalence rates vary, it's estimated that anywhere from 20 to 60% of autistic individuals have epileptiform discharges on their EEG, even if they've never had a clinical seizure. The general population estimate of epileptiform abnormalities without clinical seizures is much lower at 1 to 4%. There really is no characteristic EEG pattern for autism, and it's currently unclear why individuals with autism have a greater risk for epileptiform EEG abnormalities than the general population. Epileptiform abnormalities in autistic individuals can be focal, generalized, multifocal. They can occur on one side or both sides of the brain. A little word about electrical status epilepticus during sleep, or ESES. In children with a history of developmental regression, EEG will sometimes be used to evaluate for the presence of a severe and specific EEG abnormality called ESES, or electrical status epilepticus during sleep, that is associated with rare conditions such as Landau-Kleffner syndrome or continuous spike waves and slow wave sleep, or CSWS syndrome. In both LKS and CSWS, children present with typical early language development, followed by a rapid and significant regression in language skills, also often accompanied by regression in other developmental domains like social skills, cognition, and/or motor coordination, as is in the case with CSWS. Overnight EEG is required to establish these diagnoses, given that the profound EEG abnormalities needed for diagnosis occur during sleep. Developmental regression in autistic children is most commonly not associated with a regressive syndrome like LKS or CSWS, and is most often a result of autistic regression, for which right now we have no known cause. There are three major clinical differences, though, between children who experience autistic regression, the more common type, and those with a regressive syndrome like LKS or CSWS. Age of onset, the features of the regression, and the EEG findings. The average age of language and/or social regression in autism is 18 to 24 months, and the majority of children with autism who experience a regression will do so before the age of 3. Regression observed in LKS or CSWS occurs commonly after the age of 3 and is considered late onset, with only a small fraction, around 10 to 15%, experiencing regression prior to age 3. Autistic regression typically only affects social communication skills, language, and development of repetitive behaviors. Due to the young age in which autistic regression typically occurs, it's often subtle with loss of single words or decreased gesturing. In LKS, regression primarily affects both expressive and receptive language skills. In CSWS, regression is more global, affecting multiple developmental domains, including language, social, cognitive, and motor skills. And because of the late onset of regression in LKS and CSWS, the regression tends to be more profound and much less subtle. In autism, epileptiform abnormalities associated with regression are often coming from the central and temporal areas of the brain called central temporal spikes. They generally are pretty infrequent and occur intermittently when we're recording an EEG. In LKS and CSWS, the EEG is characterized by frequent discharges that are rising from the temporal and parietal areas that occur during wakefulness, but then become profoundly activated and nearly continuous during non-REM sleep, indicative of ESES, which you can see here on the tracing below. We don't currently have any guidance regarding the utility of EEG in children with autism with our current practice guidelines from the American College of Medical Genetics. However, both the American Academy of Pediatrics and the Child Neurology Society, in collaboration with the American Academy of Neurology, do not recommend routine testing with EEG in autism, given the high frequency of epileptiform abnormalities observed in autistic individuals without clinical seizures. Guidelines currently only support obtaining an EEG for autistic individuals where there is suspicion for clinical seizures or a history of regression. Brain imaging with MRI may be recommended for individuals who have focal epileptiform abnormalities identified on EEG. Focal abnormalities are those arising from just one area of the brain. And the reason for wanting to do brain imaging is to look to see whether or not there are any structural brain abnormalities that might be increasing risk for having discharges from that particular area. MRI stands for magnetic resonance imaging. It's a non-invasive form of imaging that relies on the use of large magnets rather than radiation to obtain the images. It is exquisitely sensitive to motion And so little children or children who have difficulty following directions oftentimes will require sedation in order to minimize movement artifact during the scan. What if your child doesn't tolerate an EEG? What if we can't get the electrodes on their head? That's okay. Seizures and epilepsy are both clinical diagnoses and do not require an EEG for diagnosis. An EEG is an incredibly helpful tool in determining the type of seizure or epilepsy and can also be helpful when there's uncertainty about whether a reported episode is a seizure or not. But we can make a diagnosis of seizure or epilepsy even in the absence of an EEG. Sedation can also be used during EEG to avoid using restraints, reduce unnecessary anxiety, minimize muscle or movement artifact, and accommodate adequate sleep during an EEG when it's absolutely necessary to get one. But there are some limitations because not every clinic or hospital offers sedated EEGs, and sometimes we can see a medication effect on EEG findings that we have to work through. Treatment with anti-seizure medication is recommended when any individual is diagnosed with epilepsy. There are many FDA-approved medications for treatment of epilepsy, some of which are specific to certain genetic conditions that cause both autism and epilepsy, such as tuberous sclerosis complex. Treatment is generally guided by seizure type, age, side effect profile of the medication, and the underlying cause of the epilepsy if it's identified. Sometimes medication might even be recommended if there's a high index of suspicion for clinical seizures, but they can't be confirmed definitively because a child can't tolerate an EEG, for example, in which case we would call that empiric treatment. A short word about anti-seizure medications. You'll see that I'm calling them anti-seizure medications and not anti-epileptic medications because the medications used treat seizures. They don't cure epilepsy. They simply help to reduce the likelihood that an individual will have another seizure. Seizures can still occur when an individual is taking an anti-seizure medication, generally referred to as a breakthrough seizure. Some individuals never achieve seizure control despite taking a medication. A person is considered to have medically refractory or drug-resistant or intractable epilepsy if they do not achieve seizure control after being on 2 or more medications at the same time. Prior to puberty, if a child's been seizure-free for 2 years, an attempt might be made to wean that child off the medication. All anti-seizure medications come in tablet or capsule form, although a lot of our patients can't swallow tablets or capsules whole. So there are other formulations available, including sprinkles, chewable tablets, and liquid. However, not all medications are available in these forms, and so when we're thinking about treatment for a particular child, we're going to be taking that into consideration. Several anti-seizure medications are also commonly prescribed off-label for treatment of pediatric bipolar disorder or behavioral disturbances, so may also be beneficial for autistic patients who have co-occurring behavioral dysregulation. Some examples of those is valproic acid, lamotrigine, carbamazepine, and oxcarbazepine. Some individuals are also prescribed an emergency or abortive or rescue medication that can be used to stop a seizure while it happens. Typically, these are prescribed for individuals who have prolonged seizures lasting more than 5 minutes. They have respiratory compromise during their seizure or have multiple seizures back to back, so this clustering without return to baseline. Emergency medications also come in various formulations, including an intranasal spray, dissolvable tablets, intramuscular injections, and rectal forms. The type of emergency medication prescribed depends on the individual's age, their size and weight, and seizure type. Sudden unexplained death in epilepsy is a rare cause of death in individuals with epilepsy. It's estimated to occur in about 1 in 1,000 people who have epilepsy per year. It's defined clinically as a sudden, unexpected, witnessed or unwitnessed, non-traumatic, and non-drowning death in patients with epilepsy, with or without evidence for seizure, and excluding documented status epilepticus, for which no other cause of death can be determined. Suspected risk factors for SUDEP include 3 or more generalized tonic-clonic seizures per year, onset of epilepsy in childhood or adolescence, nighttime seizures, intellectual disability, use of more than one anti-seizure medication or rapid changes in anti-seizure medications occurring through the year, and specific genetic causes of epilepsy like 15q duplication syndrome. Sudden death in autism is often coupled with a history of seizures. However, even in the absence of seizures, unexplained deaths are estimated to be 2.4 times higher in autistic individuals compared to the general population. We need a lot more research into SUDEP in children with autism. Because of this risk for nighttime seizures, there are a lot of different seizure detection devices on the market right now. There's a pad that goes under a mattress to detect unusual movements, cameras that send a feed to smartphones that detect unusual movements during sleep, pulse oximeters that go on the fingers that measure heart rate and oxygen levels while children sleep, and wearable watches that detect and record movements. The International League Against Epilepsy, the ILAE, current practice guideline recommends wearable devices for detection of tonic-clonic seizures in individuals who have generalized tonic-clonic seizures, although the clinical benefit with regards to the decreased risk for SUDEP or any other seizure complication remains unknown. I'd recommend for you to talk to your doctor if you witness any spells of staring with unresponsiveness, any unexplained episodes of bedwetting, blood on a pillowcase, or unexplained injury to the tongue, sudden episodes of limb stiffening or jerking, unexplained falls, unusual or bizarre behavior that is distinctly different than baseline, especially if they're recurrent, any loss of previously obtained skills, and any spell that you think might be a seizure. And I'll end with some helpful tips. If you witness an unusual spell, try to video record it. Your doctor may be able to make a determination about whether an episode is seizure or not by watching the video. If you witness a staring episode, attempt to get the person's attention by touching them. You can offer a tickle or a light pinch, or offer an activity that you know typically would garner their attention. If your child has seizures, notify their school and have your doctor complete a seizure action plan. Seizures can happen anytime, and you want the school to be prepared. And if your child has seizures, talk to your doctor about SUDEP. All right, and I'll open it up to some questions.
Yep. Thank you. What an excellent overview of seizures and epilepsy. I mean, I'm fortunate to have two kids who do have severe autism, but they don't have epilepsy. They don't have seizures. And I have so many friends whose children do, and it is tough to watch. Okay, so let's go ahead. We're going to go ahead with some questions. I also have some questions, so feel free to add more questions to the Q&A people. Okay, first, a mom has a daughter with SYNGAP1 with seizures, more at night and while eating. They're very hard to see. She said, do you have any comments about that particular genetic cause?
Yeah, so SYNGAP1 is a well-known established genetic cause for epilepsy, also commonly associated with intellectual disability, autism. There are actually some SYNGAP1 specific clinics. And so if that's something that you're interested in, I would strongly recommend reaching out to any of the clinics that have experts in SYNGAP. Yeah.
Okay. I see something in the chat also relating to a genetic syndrome. Do all children with 15q11 duplicity need to discuss SUDEP with their doctor? Is there an age that you can stop worrying?
Yeah, that's a good question. So there doesn't seem to be an age where you need to stop worrying, unfortunately. SUDEP can happen at any point. There's an association with 15q duplication syndrome, but it's unclear if it's just because we have better genetic testing now and more kids are getting genetic testing, so we're identifying the syndrome more readily. But I would definitely recommend talking to your doctor about SUDEP if your child has that specific genetic variant. I know that the advocacy group for 15q dupe definitely recommends talking about SUDEP because there's been some really good papers that have come out about SUDEP and unexplained deaths in that particular condition.
The mom with the daughter with SYNGAP says that she's severely defensive and won't wear a wearable, and that she says no clinics. She's over 21.
Over 21,
Yeah. So do you have any recommendations for her?
Yeah. Yeah, it's hard because a lot of these seizure detection devices are wearable devices. There's that pad that you can put under the mattress. There's no recommendation for that currently, and there are a lot of false alarms that go off. That's challenging if she won't wear a specific device. But we do have a SYNGAP specific expert at Kennedy Krieger. And so if you're interested, and we do see adults, and so if you're interested, I can maybe give my information to Jill and she can get it out to whoever's asking that question.
I mean, are you willing to give your email out now, maybe, or do you want to wait?
I'll
Yeah,
give you,
I'll wait.
I'll give you my information.
Okay,
Yeah.
that's fine. A
Yeah.
couple questions about EEGs. In a patient with profound autism who cannot remain still or remove electrodes, or they remove electrodes, has happened to my son.
Yeah.
There are options. Are there options for obtaining an EEG? Maybe sedation.
Yeah, so sedation is an option. Like I said, the limitations though are not every clinic or hospital offers sedated EEG. And it's technically a little bit more complicated because you need someone there who's monitoring the sedation while the EEG is happening. So it tends to require a lot more coordination with medical staff. Another option would be to consider child life. Sometimes having distraction techniques like a favorite video can be helpful. I know that I think it's Boston Children's Hospital on their website has some social stories about EEGs. And so if your child is, of the cognitive capacity to be able to sort of work through a social story to talk about what's going to happen during an EEG, that might be helpful too. And so those are some other techniques that you might consider. But really, if the EEG is really needed and your child is really adverse to having the electrodes put on, and you try these other distraction techniques, then sedation might be sort of the way to go.
Okay.
Yeah.
Everybody, you're putting questions in the chat. They didn't log on and hear me say, put them in the Q&A. So I'm trying to juggle them.
Yeah.
Another one about EEGs. My daughter had a sedated MRI last week. Our neurologist said EEGs don't work when sedated. Do they work, or should I ask
Yeah.
why?
Yeah. So we generally don't love getting sedated EEGs because the medication that's used for sedation can EEG. There are some sedation medications, though, that can be used that have minimal EEG effect, that allows us to get the information without there being a ton of medication sort of artifact within the EEG. And so if it's something that's really needed, there are ways to go about getting it.
Okay. Any insights about the link between increased inflammation and epilepsy? More seizures during the no fever infectious illness.
Sorry, say that one more
I'm
time.
I'm not sure. Do you see a link between inflammation and epilepsy?
So there are some conditions that cause central nervous system inflammation that can also result in epilepsy. Generally unrelated to the autism community in most ways, although can present with changes in cognition. But there definitely are neuroinflammatory conditions that present with epilepsy or with seizures.
Okay. Do those involve fever? I'm sorry.
They can involve fever. Yep.
Okay. If an individual hasn't had a tonic-clonic seizure, 2 in teenage years, for over 10 years, and age 34 with Phelan-McDermid, autism and ID, are they less at risk for a seizure because they're over 30? Would it be time to consider discharging the medication, in this case, Keppra? He has had a very slow regression of motor skills over the years.
So that's challenging. So, I mean, being seizure free for 10 years is really great. We know that the longer you've gone without a seizure, the less likely you are to have a seizure. And so the likelihood of this particular individual having a seizure is lower, but it's certainly not zero. So I think that that's a really good conversation to have with your child's neurologist to say, it's been 10 years. There might be side effects related to the Keppra that you might be seeing. Is it worth considering trying to reduce the medication or taking them off the medication? It's a really individual conversation about what the risks are of coming off medication, and what the potential benefits are with regards to staying on the medication.
Okay.
But being over 30 doesn't decrease your risk of having a seizure, unfortunately. Yeah.
Yeah. Can you explain again the third decade life risk again, first few slides?
Yeah. So what we were able to see is in the literature is that age of onset, or so age is directly associated with increased risk for developing epilepsy in autistic individuals. There's a peak in adolescence, but that risk for developing epilepsy continues to climb up until the third decade of life. And so after the third decade of life, it doesn't seem like getting older from there subsequently increases your risk for developing epilepsy.
Some questions about medications. Are there negative side effects of medications such as oxcarb? And I guess you could ask that of all
Yeah,
medications.
I mean, every single medication that we use, whether it's a seizure medicine or not, has side effects to it, and everyone's going to react to these medications a little bit differently. I see a lot of people putting in the chat that Keppra is awful and Keppra has a lot of side effects. Um, there can be behavioral side effects to some of these medications. Some kids and some adults will respond negatively to some of these medications with regards to behavior, irritability, aggression. Some, it's the opposite, and behavior tends to get better. But every medication has a side effect profile. Not everybody experiences all of the side effects, and even rare side effects can still occur. They're rare, but they can still happen. And so there definitely can be behavioral changes that can happen with any of these medications because when you think about it, we're altering brain chemistry with these medications, and our brain produces seizures, but our brain also produces behavior. And so when you are altering neurochemistry and changing things related to the brain, you can also have, other behavioral consequences to that as well, good, bad, or otherwise.
We have a truly unbelievable number of questions. I do want to let people know that we are going till 15 minutes after the hour today. So we have a full half an hour of discussion with Dr. Morris. So please hang on. I'm going to get to as many as I can. Okay. We have some questions about non-medication treatments. One mentioned is electroconvulsive therapy. I also know ketogenic diet is sometimes
Yeah.
used. Can you maybe address the non-medication approaches?
Yeah. So the ketogenic diet is probably the most popular non-medication therapy for epilepsy. The ketogenic diet is not recommended for everybody, but can be used with really great success in individuals who it's indicated for. Um, there are some known genetic causes of epilepsy, like GLUT1 deficiency, for example, where the ketogenic diet is the recommended treatment of choice for treatment of epilepsy. And then there are other conditions that confer risk for epilepsy where we might use ketogenic diet, especially if a child is refractory to certain medications. The ketogenic diet comes in a variety of different forms. There are very strict ketogenic diets, and then there are kind of looser ketogenic diets. They can be really challenging for kids and adults to follow because the diet is very restricted. It's easier if the child is tube fed, or bottle fed, like in infancy, or if they have a gastrostomy tube and are tube fed, because then you can just use a ketogenic diet formula. Um, it can be successful, but can be really hard. And there are side effects to the ketogenic diet, just like there are side effects to medications. Oftentimes, we'll require hospitalization to get the ketogenic diet started because you're monitoring labs really closely, and you're sort of monitoring for side effects like dropping the blood sugar too low, nausea, acidosis getting too high. And so there's a really nice balance that needs to be struck when someone's on the ketogenic diet. Um, Another sort of non-medical treatment for epilepsy, which I think it's still technically a medication, but is a little bit more complementary, is cannabidiol. And so Epidiolex is now an FDA-approved treatment for epilepsy in kids with tuberous sclerosis, and is really the only FDA-approved cannabidiol, so cannabis-based medication that's used for epilepsy. So still a medication, but a little bit off the beaten path with regards to the traditional pharmaceuticals that we use. Sometimes there will be surgical interventions for epilepsy. So things like vagal nerve stimulators, which is a device that's implanted in the neck and is activated by a magnet. And so when a seizure happens, you swipe the magnet and it sends up a discharge to the brain that helps to abort the seizure. And then there are more intense surgical options like removing pieces of the brain that are causing the seizure discharges. So much, as far as to like even disconnecting one side of the brain from the other for kids who have really refractory epilepsy. So there are a lot of non-medical options, but we generally start with medications and then sort of progress our way to these other options. And in that circumstance, your child would be seeing an epileptologist who is a neurologist who specializes in epilepsy at that point.
Thank you so much.
Yeah.
My nephew with autism just passed 2 months ago from SUDEP. Was there anything we could have done to prevent this? It happened during the day after we just spoke to him.
Yeah.
So sad.
Yeah, I'm sorry to hear that. SUDEP is one of those things that we really don't have a lot of information about. There are some large registries that are trying to collect information about SUDEP. There really doesn't seem to be a clear sort of like postmortem or autopsy-based finding that we can be absolutely certain of in SUDEP. We know that there are risk factors, right? Like having generalized tonic-clonic seizures, medication non-compliance. Sorry, so not taking your medication as prescribed, adjusting medications really frequently. But there isn't anything that we know of definitively that we say, if you do this, you absolutely will not have SUDEP. And so it's one of those things that's just really important to know about. I think it's really challenging when families are caught off guard when this happens and they say, no one has ever spoken to me about SUDEP. I didn't even know that this was a thing. As hard as it is to sort of live with that and be maybe constantly worried about it, it is really important to read about it and know about it. I don't think that there's anything you could have or should have done differently. I don't know your circumstance, but just know that there isn't a definitive, absolute cure or thing that we can do that helps to minimize the risk of SUDEP beyond taking your medications and trying to make seizures as infrequent as possible.
Yeah. Wow. Question from my old friend Sally. Hi, Sally. Is it common for seizures to get worse in young adulthood for individuals who had severe seizures in infancy and CSWS throughout childhood? Maybe you can spell out CSWS for us, doctor.
Yeah. So
It has been the experience with our son. Oh,
yes. So CSWS is incredibly rare. Continuous slow waves, continuous slow wave, spike wave, and slow wave sleep. It's commonly associated with seizures in early childhood. It tends to be that seizures tend to actually get better as kids get older, it seems, at least based on the literature. Sometimes we can see changes in seizure frequency around puberty in all individuals, not just CSWS. So it's hard to know individually, but at least the literature would suggest that as people get older, the risk for seizures declines.
another question about a genetic cause. Do you have any comments on the DL-GAP2 gene? My son has a deletion there and has autism and epilepsy.
Yeah, I don't actually know much about that one.
Okay.
Yeah, I'm sorry about that.
Let's see. My 17-year-old daughter who has severe autism and ID began having seizures last year. So that's a teen one. She
Yeah.
has been on 5 different medications so far. She's experienced severe aggression on all of the meds. Is there a medication that is safer with less severe side effects for someone who just was recently diagnosed with epilepsy?
Yeah, that's a hard one. Because sometimes medications are limited based on what she's willing to take, and so sometimes the formulations that are available for people who can't swallow tablets or swallow capsules whole, our options are more limited. And so it's possible that they might be choosing medications that your child is willing or able to take. We do know that some kids just have refractory epilepsy. And so regardless of the medication that we choose, it's just not enough. Sometimes there needs to be a combination of medications that have different mechanisms of action that are sort of working together to help control epilepsy. So without knowing the medications that she's been on or the type of epilepsy that she has, I can't give you any specific guidance or recommendation, but just know that does sometimes happen. And sometimes it really is just a matter of working through medications with your neurologist. The behavioral side effects can be very real though. And so, talking with them about other medications that might have a better behavioral profile might be worthwhile for you.
Got it. Here's mom asking if your child has multiple seizures starting in adolescence, but no clear finding in EEG or MRI and nothing from genetic testing. What do you make of that?
Yeah, that does sometimes happen. It can be frustrating, I think, but it does sometimes happen. When we do EEGs, oftentimes the child isn't having a seizure at the time of the EEG, and sometimes that EEG can be normal in between seizures. It doesn't have to have an abnormality. And so to have a normal EEG does not necessarily mean you don't have epilepsy. The same with an MRI. A lot of the times, the MRI is going to be normal without there being any clear indication that that child has a structural abnormality or something in their brain that might be increasing risk for them having epilepsy. And it's the same for genetic testing, too. About 10 to 15% or so of kids with autism will have a positive genetic test. And so most of the time it's negative or normal. So you're sort of falling in this hole of, you're not getting a ton of information from the testing that we have available. But if there's high clinical suspicion that these really are seizures, then treating is the way to go. If you're not quite certain that they're seizures, or if the doctor's not quite certain that they're seizures, then that's when you might rely on a longer study, a longer EEG to try and actually capture a seizure or whatever spell you're thinking might be a seizure, because that's really going to be your most definitive answer. The EEG is on the head, the child has a spell, and you can read the EEG and say whether or not it's a seizure. If it's not a seizure, then you may not need medication. But if it is a seizure, then you have your answer.
Okay, so many questions. Some questions just about practice. Like, what do you recommend? Somebody is concerned about seizures with their child. What are the best neurologists, the best facilities to go to? Do you have any just basic advice for where they should go for help?
Yeah. So, if it's a new onset seizure, generally you're probably going to find yourself in the ER, which is a good place to be for a new onset seizure. And generally at that point, if it's pretty simple seizure and or new diagnosis of epilepsy, you'll be referred to either a pediatric neurologist if your child's under the age of 18, or an adult neurologist if the person is over 18. Usually a general neurologist is capable of managing pretty simple seizures and pretty simple epilepsy. But if the epilepsy is becoming more complicated and you're working through medicines, or your child's not responding well to them, or if the seizure type is a little bit unusual, or if your child has a known genetic condition, you might be referred to an epileptologist who is an expert in epilepsy. And from there, if you're looking for more specialized care, any of your big tertiary or quaternary academic centers are going to be where you want to be, because that's really where most of the experts live. And so places like Boston Children's Hospital or Baylor College of Medicine or any of the University of California schools, if you find yourself in a big academic center, that's where most of your research is going to be. That's where most of your experts in really rare genetic causes of epilepsy are going to be. And if you're interested in research, that's where your research opportunities are going to be. But community neurologists and community epileptologists are good too. It's just if you're looking for that extra layer of expertise, going to one of these academic centers would be the best case scenario.
Okay, I'm going to try to go through these quickly. Interesting question. Is squinting, squeezing eyes shut a sign of seizures?
That's a really interesting question. So I never say never, but generally speaking, closing your eyes is not usually a sign of seizure. Usually the eyes remain open. And so if the child's eyes are closed, or if the person's eyes are closed that you're thinking is having a seizure, the likelihood that it's seizure is lower. So we generally use eyes open. Seizures are activating. Seizures produce discharges in the brain. And so like things like numbness, closing of the eyes, sort of these negative symptoms generally are less associated with seizures. That being said, seizures can produce a lot of funny things. I had one little boy who would stand in the toilet during his seizure. He would walk around the house and they'll go stand in the toilet, which was a very bizarre, different thing that was never usual for him. And it ended up being a seizure. And so seizures can present in a lot of funny, weird ways.
A couple questions about behaviors that are either before or after a
Yeah.
seizure. Do you see aggression or self-injury spiking at all in association with a seizure?
So you certainly can. There usually is some prodrome that occurs prior to the seizure. It might be incredibly brief, or there might be this longer aura that happens. And I'm thinking in the context of someone who maybe isn't able to communicate exactly what they're feeling or thinking at the time. If there's some sensation that's happening and there isn't a way to verbalize that or to communicate that in some way, or really they just don't know what they're feeling, then I could certainly see a scenario where aggression or behavioral disruption might sort of increase as a way to sort of garner that attention that something's not feeling right inside. Sometimes it's just, a simple upset stomach or this like weird feeling that they get inside. So there definitely can be these prodromes, these auras that happen prior to seizures. That's usually in the context of a focal seizure. And then behavior after seizures tends to be sleepy. We call it a post-ictal state where people tend to be sleepy. They tend to be maybe just a little bit less responsive, less energetic. And it usually lasts maybe 10, 15 minutes or so before they're back to their usual self. So it's not unusual for a child to want to go right to sleep after they have a seizure.
Here's a kind of related question. Is there any link between, self-injurious behavior to the head? So,
Yeah,
head banging in autism and the development or occurrence of epilepsy or
yeah,
seizures?
yeah. So self-injurious behavior to the head as a cause for epilepsy or just occurring in the context of
Um,
either or.
yeah.
So self-injurious behavior to the head, unless it's causing injury to the brain, I would not think of as a cause for seizures or epilepsy. Um, so external injuries to the face and the head without there being injury to the brain, generally not a cause for epilepsy. That being said, self-injurious behavior to the head, banging head, rubbing eyes, knuckles in eyes, those sorts of behaviors um, certainly could be, depending on the sort of function of the individual and how well they're able to communicate to you what they're experiencing, because we can see seizures where it's just flashing lights or odd colors that are happening in the eyes, or perhaps a strange tingling sensation in the face. And the way that that child or that individual is communicating that there's something going on is aggression or some sort of indication that there's something going on. If the self-injurious behavior has been occurring for years and years and years and years, and it seems pretty typical, then I would be much less concerned. But if it's new out of the blue and it's something that is really unusual and bizarre for your child or for your loved one, I would definitely recommend talking to their doctor about it and saying, this is new behavior. I'm not quite sure what it is. Other things that come to mind, headaches, you know, but certainly unusual focal seizures could produce something like that.
Got it. Thank you. Um, Question about just generally about with drug interactions. So if you're on anti-seizure medications, should you be concerned about other drugs that the child might be taking? This person mentioned Paxlovid, but perhaps there are others because many of our kids and adults are on
Mhm.
multiple meds.
Yeah. So there are definitely interactions that our seizure medications have. Um, Keppra, which I know has been brought up, has very few drug interactions. Um, but other older medications, like valproic acid, for example, has far more involvement with liver metabolism. Things like clobazam, which is a relatively newer medication, can generally be affected by other medications. And so if your child's put on antibiotics, it's important to let your neurologist know. If they're started on a new medication for heart issues or really anything, it's important to let your neurologist know so that that way they can look for any drug interactions and potentially adjust the dose of the medication, because sometimes the interaction isn't just that, they don't play well with one another, but sometimes these medications will actually decrease the efficacy of seizure medications. And so the dose needs to be increased. Other times, medications might increase toxic metabolites of our seizure medications. And so you're at higher risk for having unintended side effects. So anytime there's a new medication that's added, talk to your doctor about it to make sure that there aren't any changes that need to be made.
There's some questions around nutrition and microbiome, and
Okay.
if that could either affect the risk for seizures, like poor nutrition, or if some sort of treatment to the microbiome could help alleviate seizure activity. Thoughts?
Yeah, so I don't know of much research in the realm of microbiome and seizures. I know that their microbiome is a really hot topic right now, just in the autism community in general, with regards to research. But I don't know of anything that has specifically been done with regards to risk for epilepsy or seizure control in that particular regard.
Okay. Hormones. How do the child or the adolescent's hormones interact with seizure risk?
Yeah. So seizures do seem to peak in puberty. There seems to be an uptick around puberty with regards to seizure frequency. Like we had mentioned, there's that peak in adolescence that happens with the development of epilepsy. So you can go through your whole childhood and then get to that adolescent phase and develop epilepsy. So we think that there's probably some hormonal component to the production of seizures. No one has really been able to figure it out. For girls, there is something called catamenial seizures, which means that they're seizures that happen in the setting of their monthly menstrual cycle. And so if you're noticing bizarre behavior and it's happening cyclically, and it doesn't look typical for your child, it would be worth talking to somebody about it, because sometimes we really can see this hormone-driven production of seizures in teenagers.
Yeah, a mom actually wrote in a question about
Yeah.
catamenial seizures,
Yep.
which occur in her daughter.
Yep.
Wow. Okay, I do want to mention, by the way, disclaimer, we do not provide any medical
Yeah.
advice at NCSA, and this is not meant to provide you any specific medical advice about your child health. This is only for informational purposes only. Please see a doctor about your specific case. But people do have specific issues with their kids, but know that what Dr. Morris is saying does not qualify as medical advice.
That's right.
My son is 19 and his first seizure was at age 9. He has been stable on oxycarbazepine. I can't even.
Oxcarbazepine. Yep.
Thank you,
Mhm.
750 milligrams twice a day. He has had only one breakthrough seizure back in 2020. Should we assume that he will always need to be on the meds? Is there any hope he could grow out of his seizures?
Yeah. So in general, at least in pediatric neurology, if a child has been seizure-free for more than 2 years, we do consider weaning the medication. It's a case-by-case basis, though, because it kind of depends on what your child's EEG looked like, depends on how severe the seizures were, depends on how long the seizures were. If your child is a child who tends to have really long breakthrough seizures that always require a rescue medication or land them in the hospital, then it might not be worth weaning the medication. And so we definitely do try to get kids off medication, but if there's a risk associated with coming off that medication and they're doing really well on it and are very stable tolerating the medication, then your neurologist might choose not to come off of it. And so it kind of depends. There's a lot of different factors that can go into, but I would definitely recommend, it's been a long time. It's been 4 years. Congratulations. To definitely talk to your neurologist about it and see what their thoughts are.
Yeah, great. We definitely have more questions about CBD and ECT,
Yeah.
which we went over already, but with regards to CBD, maybe you could just quickly reiterate what you said about
Yeah. So CBD, so CBD oil, cannabidiol oil, there is one FDA approved form of cannabidiol, which is Epidiolex. It's still branded and is only FDA approved for use in one specific type of epilepsy, medically refractory epilepsy in the context of tuberous sclerosis syndrome. It is not FDA approved for any other indication. CBD oil that you can get on Amazon or at dispensaries or elsewhere in the country are not FDA regulated. There's no way for anybody to know what's actually in that. And we have no medical guidance regarding the utility of CBD. We do know that CBD interacts with other medications. And so I think I saw someone put in there that about something about OTCs, over the counter medications, that even supplements like St. John's wort and things like that, supplements can interact with seizure medications too, just like CBD can. And so disclosing all of the different supplements that you might be taking or that your child might be taking in the context of seizure medication is really, really important.
ECT, did you want to say anything about
ECT. So
yeah.
ECT, what a loaded topic, ECT. So ECT right now is used incredibly rarely in children who have life-threatening epilepsy, and it is a complete off-label use for it. It's usually kids who are in the ICU have life-threatening epilepsy. It is not used otherwise at this point clinically for treatment of epilepsy. It's used for other indications in the autism community, like catatonia, for example. It's used for major depression in sort of the general population, but for epilepsy, it's used incredibly rarely. And is certainly not something that I think most academic institutions do. Oh, ECT is electroconvulsive therapy.
Here's a mom whose kid has the whole enchilada, grand mal, absence, and subclinical seizures only seen on the EEG with
Yeah,
ID and level 3 autism. We've noticed regression in behavior and skills when her medication starts to fail, likely due to the increased epileptiform spikes.
maybe.
We have prioritized mitigating absence and grand mal seizures over the subclinical seizures. Ooh, that's a lot going on,
Yeah,
Mama. Is it wise to continue to prioritize grand mal and absence versus
yeah,
subclinical? That's
yeah. Yeah, you're doing great. You described that really well. So in general, we always want to strike a balance between seizure control and quality of life, right? Our seizure medications can cause a lot of drowsiness. They can cause a lot of confusion. You can get into this mix of what we call polypharmacy, where there are a lot of medications that are just building on top of one another and can actually start to really affect a child's cognition and their ability to think and focus. Um, and so we know that the grand mal seizures, those generalized tonic-clonic seizures, are those kind of big risk seizures when it comes to things like SUDEP. Absence seizures can really affect a child's ability to focus and pay attention and interact. Um, and those are the ones that are clinically apparent. And so I think prioritizing those is, probably a good step. And if it's hard to manage those subclinical seizures without completely altering or being on so much medication that it's decreasing your child's quality of life, then that seems like a good balance to strike. But sometimes that happens where we have to allow some seizures. We need to be permissive of some seizures because otherwise the alternative is just a really overly medicated child, which is not good for their quality of life either.
wow. Okay. I have a 21-year-old son who has failed 3 meds, presently taking Xcopri and Topamax. He had VNS for 2.5 years. They last approximately 1.5 minutes long. We use VNS magnet and nasal CBD spray as a rescue. He's having seizures every week to 25 days. Any recommendations?
He's got complicated epilepsy. He has, medically refractory epilepsy. So the VNS is that vagal nerve stimulator that I was talking about earlier. He's on a couple of different medications, uses rescue medications regularly. That's a really challenging epilepsy. And so I personally don't have any recommendations for you beyond continuing to work with your neurologist or your epileptologist to help control the seizures. It's a lot, though. You can see that managing a child with epilepsy can be a full-time job for sure.
A lot of people are asking, like, do they grow out of it? And you've addressed that a couple times. And
Yeah, I mean, we don't really think about people growing out of seizures, but some people will stop having seizures. And we don't know why. Just like the development of epilepsy is unpredictable, who's going to end up being seizure free and outgrowing or will stop having seizures is also unpredictable. There can be people who can go years, decades without having a seizure, and then they have another one. It's really, really unpredictable, but we don't think of it as something that you outgrow necessarily, but you definitely can stop having seizures.
couple questions relating to genetic testing. I think people
Yeah.
are a little bit at sea about that.
Yeah.
Where to go, what to do. Do you have any general recommendations?
Yeah, so I think the general consensus is that genetic testing is recommended pretty much for all kids who have a diagnosis of autism or global developmental delay or intellectual disability. And genetic testing is certainly recommended for kids who have epilepsy. There are a lot of different types of genetic testing that are available now. There are, specific epilepsy panels that can be sent. There's whole exome sequencing where we're sequencing the entire coding region of the gene. There are like microarray panels looking for gene deletions and duplications and things like that. And so most neurologists can order genetic testing. There are some insurance companies that require patients to see a genetic counselor before genetic testing is sent. And so if you're curious about genetic testing and are interested, I would definitely talk to your neurologist about what options are in your area for genetic testing. But most major medical centers will have genetic testing options. There are also research genetic testing as well that some people can think about. So there's something called the Spark study, which is part of the Simons Foundation. It's a international research study looking at genetics and autism, and included in that are genes that are associated with epilepsy as well. And that involves whole exome sequencing. And so if you just Google Spark, that's a genetic registry that is available for all children and individuals who have autism.
Yeah, I would definitely recommend that. It is free and
Yeah, it is.
a very robust study, but it doesn't return a lot of results because
Yes,
because the genetic markers are relatively rare.
that's right.
Okay, definitely important question. A lot of people asking about the slides. Can we share your slides? Can we get your
Yeah,
present?
I can send them to you, Jill, if that's
Okay.
the easiest way to do it. Yeah.
Okay.
Yeah.
Yeah, that's great. I'll post them on the webinar under, the link to the video. I'll also have a link to the slides, which I know will be
Okay.
easier for
Perfect.
people. Somebody asking about insulin nasal spray for seizures.
Insulin nasal spray. I have not heard that one.
Okay.
I'm not familiar with insulin nasal spray. Yeah.
Okay. Here's something about a genetic
Okay.
disorder. I have 3 children with PRRT2 gene defect and PKDK. One
Okay.
of the 3 has T18 and refractory epilepsy, regression after age 10. Any comments on that?
I
Wow,
don't
wow,
yeah,
mom.
I don't have a lot. I don't have any specific comments on that,
Okay.
unfortunately. Yeah.
Well, that's a case study and a half to have
Right.
3
Yes.
kids with that. I
Yeah.
hope that somebody in your area will study your family because
Yeah.
that is highly unusual and really you should be the subject of a paper.
Yeah.
Um, let's see. I've observed staring off sessions is not arousable, even with the strongest motivator, and moves in and out, suddenly losing track of what he is doing. My son just learned a letterboard and explains he loses track of his thoughts.
Mm.
If our children can communicate, what should we be asking them to report to us?
It's a good question. I like the thought that he's losing his thoughts. Sometimes kids who have the ability to communicate will communicate this idea that they're losing time, that they pay attention, like at school, they'll be paying attention and then they feel like they missed what the teacher said. And there's like a whole chunk of time where they aren't able to recall anything that the teacher said with absence seizures. Um, that's really it. It really is sort of this loss of time with absence seizures because there really isn't other like aura or anything else that generally comes with it, but just this sense of like, I lost time and I'm not sure where it went. So the fact that he's saying he's losing his thoughts is sort of compelling.
Hmm. We'll do some quick questions and then wrap it up. How about helping our kids swallow pills if they can't? I mean, it seems
Yeah,
like that's an ABA kind of question, or maybe
totally.
there's a device.
Totally.
Um,
So I have two thoughts about that. The one, definitely getting a behavioral therapist. So there definitely are behavioral therapists who are expert in medical desensitization. So like getting them used to an EEG, getting them used to swallowing pills. And so there definitely are behavioral therapists to do that. We have a couple at the Kennedy Krieger Institute that do that. Another favorite of mine is using mini M&Ms. If they don't swallow them, they just chew them, and there's a little bit of a reward to learning how to swallow pills. So you can always start with the mini M&Ms and then graduate up to the bigger ones, and that way it's not so challenging. If they chew the M&M, they chew the M&M, and they get a little treat.
Okay. Well, I hate to say that we have to wrap it up. I'll do two more and then we will depart, unfortunately. Hopefully we can have
Mhm.
Dr. Morris back again. Question about just sensory overload. Is that related to the conduct of a seizure? What have you seen?
Yeah, probably not. So, sensory dysregulation certainly occurs in the context of autism alone, whether there being, hypersensitivity to sensory stimuli or undersensitivity, the sense of like sensory overload or being overstimulated. I don't routinely see in the context of it being associated with seizure or epilepsy. So is likely probably more just related to sensory regulation on its own. Working with an occupational therapist who does like sensory integration therapy can be really helpful for that.
But strobe lights might be the exception, right?
Strobe lights can be an exception. So
Yeah.
there is photoactivated epilepsy. I didn't talk about that in today's talk, but there is photoactivated epilepsy. It's rare, but it does happen. So you see those, warnings on movies or amusement park rides or whatever. There's also some seizures that can be triggered by hyperventilation. So breathing really rapidly can trigger something like an absence seizure. There's even some really interesting epilepsies where children will look up usually at a light or at the sun and will sort of wave their hands back and forth and create sort of a strobe light effect, and that induces seizures. And so you can
Wow.
imagine how challenging it can be in the context of a child who has sensory regulation issues and might be sort of just visually stimming, or are they actually trying to sort of invoke a seizure. And so, again, working with your neurologist, taking videos of the things that you see, videos are really, really helpful. And when in doubt, trying to evaluate a little bit more.
A lot of our kids don't sleep. Is sleeplessness associated with risk for seizure?
Sleep deprivation is absolutely associated with increased risk for seizures. So, working with a sleep medicine specialist, or working with your pediatrician to regulate sleep can be really, really helpful, especially for kids who have a diagnosis of epilepsy and reducing the frequency of their epilepsy or frequency of their seizures.
Okay. Well, I hate to call it a day. I'm going to ask my friend's question here. I'll
Okay.
leave it with you, Alicia. How effective is Epidiolex? Is there less side effects with a med like Epidiolex? Less side effects.
Yeah, so Epidiolex is a really effective medication for the treatment of medically refractory epilepsy in the context of what we know that it's helpful for. There's new ongoing studies related to the use of Epidiolex for other types of epilepsies. It does have a side effect profile just like any other medication, but seems to maybe be a little bit better tolerated. Has a lot of drug interactions with some of the medications that we routinely use in medically refractory epilepsy, though. So I think that that's probably the biggest thing that people have to be aware of, that Epidiolex and the medications that are commonly used for intractable epilepsy tend to interact with one another and alter each other's levels. And so that tends to be sort of a balancing act that needs to happen when there's a child who's on Epidiolex.
Gosh, I'm gonna ask one more question.
Okay.
This woman's daughter is allergic to sodium channel blockers, and the
Um,
neurologist added
mhm.
Diamox, which is a diuretic, and it helped her. Do you have any reflections on that?
Yeah, so there are some genetic causes of epilepsy where sodium channel blockers are not indicated, where we should avoid using sodium channel blockers. Sodium channel blockers are a class of seizure medications, and there's a bunch of them that sort of fall in the class of sodium channel blockers. There are then other genetic conditions that sodium channel blockers are the medication that you should be using. And so, again, sort of going back to genetic testing, if your child has epilepsy, genetic testing can be really helpful, not just to inform why your child has epilepsy or autism or intellectual disability or whatever else they might be dealing with, but it can also be really helpful for treatment too. It can help guide the doctor to say, okay, what medicine should we be using? Are the medicines we're currently using the right ones? And so having that genetic testing piece, if it comes back positive, can be really helpful.
All right. And with that, thank you so much. I don't think I've ever seen so many questions in all my years of doing webinars. So I think that's a hint that we'll have to have you back again. Dr. Morris, thank you so much for your time. I will
Yeah.
post this and also the slides. Any parting words before I end the webinar?
Thank you so much for having me. I would love to come back and do this again. You guys are all amazing. Good luck with everything. Kisses to your kids.
Mwah.
Yep.
Thank you, Dr. Morris. Good night, everyone.
Yep. Bye-bye.